Micturition Part 2. In the Part 1 you have learned about the physiological anatomy of urinary bladder and its nerve supply. Now in this Part 2 you will learn about how urine is transported from kidney to urinary bladder and relationship between the volume and pressure change due to filling of the bladder and the reflex activity of urination. As you know the nerve supply of bladder, let's find out from where it is controlled. Micturition is a spinal reflex and its center is located in the spinal cord segment S2, S3 and S4, and it is a reflex center of parasympathetic nerve that controls the contraction of the detrusor muscle, the main muscle of the bladder, and relaxation of internal sphincter. Now contraction of the detrusor muscle and relaxation of internal sphincter. Now urine will be passed through the urethra. As I have said that it is a reflex action, so whenever the bladder is full, that is the pressure inside the bladder reaches to critical level, urine will be passed by the reflex action. Then it will be an embarrassing situation for anyone. If the bladder is full, then without any control urination occurs. Then it comes the control of the higher center. So control of a higher center is required. So the higher center, the micturition facilitatory center, is found in pons and posterior hypothalamus. So we can see that this area is the pons and this area is posterior hypothalamus. Now these two areas facilitate the micturition process, and inhibitory area is found in the midbrain, and so this area, this red area, the midbrain area, this area is inhibitory for micturition. Now other cortical areas that also affect the process, like frontal lobe motor area and superior frontal gyrus. Next is how urine is transported from the kidney to urinary bladder. From the collecting duct, so I have a enlarged view of a nephron here, and from the collecting duct urine flows through the renal calyxes. These are the renal calyx, this is minor calyx, and from there, that is urine from the collecting duct comes to the minor calyx, and from the minor calyx it comes to major calyx. Now kidney has got about 2 to 3 major calyx and about 8 minor calyxes. Now as urine flows from the minor calyx through the major calyx and to the renal pelvis, this here is the renal pelvis, you can see this here is renal pelvis. As the urine flows, it stresses the calyxes, that is it stresses the major calyx, minor calyx, and that induces a pacemaker activity, and that initiates peristaltic contraction which spreads through the renal pelvis and downward along the length of the ureter. So the urine is moved from the renal pelvis through the ureter towards the urinary bladder. Now this peristaltic movement is about 2 to 6 peristaltic movement per minute. Now ureter has got both sympathetic and parasympathetic supply and a internal plexus of the nerve along the entire length of the ureter. So the peristalsis is increased by parasympathetic activity. Increased peristalsis by parasympathetic and decreased peristalsis by sympathetic activity. Okay. Now from the ureter, urine comes to the urinary bladder. Now you know ureter goes obliquely through the detrusor muscle. Here ureter goes obliquely through the detrusor muscle. Now normal tone of the detrusor muscle tends to compress this ureter opening or the opening slit of the ureter. This is the opening and this is the detrusor muscle, and it goes obliquely through the detrusor muscle. So normal tone of the detrusor muscle tends to compress the ureter opening, and when the pressure becomes more inside the bladder, it will compress and the opening will be closed. Now what happens when urine comes through the ureter, and then there is in each peristaltic movement there is increase in pressure inside the ureter. So the region passing through the bladder wall, the region that is passing through the bladder wall is now open. So urine can pass through the opening slit of the ureters. Got it? The peristaltic movement of the ureter, there is increased pressure inside the ureter. So the ureter which was passing obliquely through the detrusor muscle now opens due to this pressure inside the ureters. So now urine has reached the bladder. In some people, the length of the ureter inside the bladder wall that passes obliquely is less than the normal. So when there is increased pressure inside the bladder or during micturition, sometimes the ureter is not closed completely. So urine is propelled backward into the ureter. So it will make the ureter pressure increased and ureter will be enlarged, and this back pressure also goes to the renal pelvis, and from the renal pelvis to the calyxes. You know, these are the calyxes. These are calyxes. So the calyx, and it also damages the medulla. So this back pressure damages ureter, renal pelvis and the calyxes and also medulla. This is called vesico-ureteral reflux. Vesico-ureteral reflux. That is, vesico means bladder and ureter, this is ureter. So vesico-ureteral reflux. As you know, ureter is richly supplied by nerves. So when suppose it is blocked by a stone, and this produces a reflex constriction, this stone causes a reflex constriction of the ureter, and there is severe pain sensation, and this severe pain leads to constriction of renal arteriole. Pain, constriction of renal arteriole. So it also then leads to decreased urine output. Decreased urine output, and this is called ureterorenal reflex. This is called ureterorenal reflex. Ureterorenal reflex. Remember, this is ureterorenal reflex. Now let's find the filling of bladder and the pressure change in the bladder. Now when urine is collected in the bladder, there is increase in volume of the bladder, and that will increase the pressure inside the bladder. So when there is no urine, the pressure will be 0. Pressure here we take as centimeter of water. Now when about 30 to 50 ml of urine is collected, the pressure increases to 5 to 10 centimeter of water. Now when it becomes filled about 200 to 400 ml, in that case there is a small rise in pressure inside the bladder. Now why this happens? Because in 30 to 50 ml there is increase in 5 to 10 centimeter of water, but a large increase like 200 to 400 ml there is small rise in pressure. Why this happens? This happens due to plasticity of the bladder wall. Now what is plasticity of the bladder wall? Suppose this is a bladder, and when this bladder is filled with urine, then what happens? The urine now stresses the bladder wall. It will stress the bladder wall by the pressure inside the bladder wall. So initially there is increase in pressure, but after some time the muscle fibers relax, and this relaxation of the muscle fiber, so there is a increase in the volume of the bladder. So the intravesical pressure tends to drop back towards the initial value. So tension initially produced by the stress is not maintained. So the main reason behind the constant or almost constant level of pressure is due to this plasticity of the bladder wall. Relation between urine volume and intravesical pressure can be studied by inserting a catheter and at first empty the bladder, and then we will infuse 50 ml of normal saline through the Foley's catheter into the bladder. 50 ml normal saline, and we will note the pressure. Again we will fill the bladder by another 50 ml of normal saline and note the pressure. By continuing this process we can get a curve, and this curve is called cystometrogram. Now in cystometrogram, in x-axis we get the intravesical volume in ml, and in y-axis the intravesical pressure, that is in centimeter of water. Remember, it is centimeter of water. So at first, when we infused 50 ml of normal saline, the pressure rises, and this is 50 ml of normal saline. It is called phase 1A. After that, when we infused another 50 ml and so on, another 50, like this, then the pressure change is minimum, or we can say a constant level of pressure is maintained in this region. A almost constant level of pressure is maintained. It is called phase 1B. When we reach the 400 ml, 300 to 400 ml mark, then the phase 2 starts. That is, beyond that, a small amount normal saline infused can increase the pressure a very large value. So get it? After 400 ml, see that the pressure rise is very much greater. So in this 1B or basal cystometrogram, that is the almost constant pressure, how it is maintained? You know one point, that is the plasticity of bladder. Plasticity. So the fiber relaxes when the volume increases, then the fiber relaxes and the pressure remains almost constant. Now next, number 2, we can assume bladder as a hollow and almost thin-walled spherical organ. So it will follow the Laplace's law. It will follow Laplace's law. Now what is it? Pressure P is equal to 2T by R. T is the tension and R is the radius. Now as the urine enters, and it will increase the tension in the bladder wall. Urine enters into the bladder, it will increase the tension of the bladder wall, so T is increased, and this also increases the radius of the bladder wall. As we know that the detrusor muscle relaxes and the diameter or the radius is also increased. So the numerator, that is 2T, and denominator both are increased. As the both are increased, so the ratio, that is the pressure, it remains almost constant level. Okay, as the tension is increased and the radius of the bladder is also increased, so the ratio of these two, that is the pressure, that remains almost constant. Along with the tonic pressure changes during the filling of bladder, there are periodic superimposed waves which last for few seconds to few minutes and can be of few centimeter to 100 centimeter of water. These are the contractions, and these are called micturition contraction or micturition wave, and these are due to the micturition reflexes. When the urine volume in the bladder is 150 ml, there is sensation of the bladder fullness, and when the bladder is filled with 400 ml of urine, then a strong urge for micturition is felt, and when it reaches 600 ml, pain is felt. Okay, so 150 ml there is sensation of bladder fullness, 400 ml strong urge, and in 600 ml there is pain felt. Micturition is a spinal reflex, that is, when the bladder is filled with urine, so it will stress the bladder wall, and that will again stress the stress receptor present in the bladder wall and posterior urethra. That will go to the sacral segment, that is, this is the sacral segment, this segment is the sacral segment. So the signal will go to the sacral segment, and the signal again come back to the same way to the bladder via the parasympathetic nerves. So the center is located in the S2, S3 and S4. So micturition is a spinal reflex action, but it can be controlled voluntarily by contracting the external urethral sphincter and via the influence of the higher brain center, that is inhibition by the midbrain and facilitation by the pons and posterior hypothalamus, and there are some influence of the cortical area, and it can be initiated voluntarily by relaxing the external sphincter and lowering the pelvic floor, and this lowering of pelvic floor stresses the bladder wall and opens the internal sphincter, and this will activate micturition reflex. Now contraction of the abdominal muscle and diaphragm will also increase the intra-abdominal pressure, and that will help in emptying the bladder. During micturition, the external sphincter and the perineal muscle relaxes and detrusor contracts. And last few drops of urine which is present in the urethra is expelled by the contraction of the vulvocavernosus muscle in male and by gravity in female. So in a nutshell, bladder wall is stressed and sensory stress signal from the bladder and posterior urethra will go to the pelvic nerve, that is the afferent pathway, to the sacral segment S2, S3 and S4, and from there it will go to the again the pelvic nerve, that is the efferent pathway now, that is parasympathetic, and it will again go to the bladder and initiate the micturition reflex.